Hello guys, welcome to my channel once again. Today we'll be talking about liver function test. So we'll look into what liver function test is, and we'll be looking at when to request for liver function test and the relevance of liver function test. Then we'll look at a case studies. So when do you request for a liver function test? So somebody with jaundice, you have to request for liver function test because in most cases it may be from the liver. Then somebody with right upper quadrant abdominal pain, a patient with hepatomegaly, a patient who has a history of alcohol use, a patient with suspected viral or alcoholic hepatitis or any inflammation of the liver, then a patient with overdose of paracetamol or any other hepatotoxic drug, then a patient with ascites or edema, then a patient with altered mental status, that's if the patient is confused or delirious, because it could be a hepatic encephalopathy. Then a patient with coagulopathy because the liver produces clotting factors. So a patient with preeclampsia because of what we call HELP syndrome, which normally happens in severe preeclampsia. Then a patient that we are monitoring treatment of a liver pathology. We do liver function tests to see the progress of the treatment. So what are the components of liver function test? So I simplify it in this abbreviation ABCE. So the A represents albumin or protein. So the albumin is just part of the protein. So you may get a total protein and albumin aspect of it. Then we have bilirubin. So liver is supposed to conjugate unconjugated bilirubin so that it can be excreted by the kidney. So if the liver is dysfunctional, that function of the liver will be impaired. So bilirubin will pile up in the blood. So the third one is C, which is clotting. As I said, the liver synthesizing most of the clotting factors. So both the procoagulant and the anticoagulant factors. So the procoagulant factors, we have the clotting factors, except factor 13. Then we have the fibrinogen. Then for the anticoagulant factors, we have the protein C, protein S, protein Z. So they are responsible for anticoagulation and then antithrombin 3. Then for the enzymes, these enzymes are expressed in hepatocytes. So we have the AST, which is the aspartate transaminase or aspartate aminotransferase. So aminotransferases are supposed to work in amino acid metabolism. So they are supposed to transfer amino group from the amino acid to another element or another functional group. So they are used in amino acid metabolism, which is key in the liver function. Then we have alanine transaminase or aminotransferase. We have alkaline phosphatase. So alkaline phosphatase is used in bilirubin production or bile production. So usually when you have biliary tract abnormalities, you will have alkaline phosphatase increasing or elevating in the blood. So for the aspartate aminotransferase, it's expressed in the liver, it's expressed in the brain, even skeletal muscles or the heart. So when you have any abnormalities at these sites that I've mentioned, you may have the AST being elevated. It's also an acute phase reactant. That means it's elevated in acute inflammation. So it is not liver specific like that. Now, ALT is 90% expressed in the liver, even though minor ones can be expressed in other cells or other tissues. The liver expressed majority, so it's more liver specific. Now, GGT is gamma glutamyl transferase. This enzyme is a transmembrane enzyme used in glutathione metabolism. It's also used in leukotriene metabolism. So we know glutathione is responsible for reducing reactive oxygen species and their effects in the body or on the cells. So it is used in detoxification of some drugs as well. So usually when the patient presents, you compare the patient's symptoms with the functional or the liver function test. You don't just explain the liver function test in isolation. So you correlate the liver function test to the patient's symptoms. So at times we don't use the absolute values of these parameters. At times we use ratios as well to tell us where the pathology is coming from. So for example, AST to ALT ratio helps us to know whether the pathology is an inflammation or hepatitis, or helps us to know whether it is from alcoholic liver disease. Now, in alcoholic liver disease, GGT and ALP will be elevated markedly. However, we also use the ratio of AST to ALT. That's what we call the Wright's ratio. So the Wright's ratio is AST over ALT. So usually if the ratio is more than 2 or 2 or more, then it is more of alcoholic liver disease. But if the ratio is less than 2, then we know it's most likely to be a hepatitis, either viral or any other hepatitis, mostly viral. Now, the liver has some functions. So basically, the liver has metabolic functions. So the metabolic function, it could be anabolic or catabolic. So the anabolic ones are synthetic functions of the liver. So the liver synthesizes clotting factors. So usually if the liver is diseased or there is a liver pathology, the clotting factors are reduced. So we check for the vitamin K dependent clotting factors, which we use the marker prothrombin time, or INR, which is international normalized ratio. So usually if it is more than 1.5, if the INR is more than 1.5, then we are afraid, meaning there is a deranged clotting. So we'll look at the case and we'll know how we'll apply all that we've just learned in the case. So a 28-year-old commercial driver presented to the clinic with anorexia and malaise of 5 days duration. He had fever and vomiting twice. He could recall that he had joint pains, so the pain involved the knee, elbow, and wrist, with no obvious swelling of these joints for the past 2 weeks. He has no significant past medical or surgical history. He is married but rarely sleeps home because of his work. He never smoked but occasionally takes alcohol. On examination, he is febrile and looked jaundiced. There was tenderness on the right upper quadrant, with the liver edge palpable 3 centimeters below the costal margin. That's at the mid-clavicular line. His BMI was 22.4. All other examination findings were normal. So the liver function test was shown in the next slide. But let's look at the key points in this case. So a 28-year-old, meaning is sexually active, a commercial driver. So the occupation of the patient also tells us the risk. Now the patient presented with anorexia, malaise for 5 days, then arthralgia. So joint pain without joint swelling is arthralgia. So the constitutional symptoms of viral prodromal infection or prodromal signs, these are pointing to a viral infection. So it has no past surgical or medical history. That means it's something acute that's happening. So on examination, the key findings on examination is febrile, so it's possibly infectious. Then jaundiced, tender right upper quadrant pain, so tender right upper quadrant of the abdomen. The liver is enlarged, so this is telling us that it's an inflamed liver from a viral cause, because we established the viral etiology possibly already. Now let's see what the liver function test shows us. So AST was 120 with upper limit of 35, ALT 350 with upper limit of 45, so it's markedly elevated. Then alkaline phosphatase was 250 with upper limit of 120. GGT was 35 with upper limit of 30, so it's elevated but not much. Bilirubin was 26 with upper limit of 17. So usually when they mention bilirubin without specifying what type of bilirubin, it's total bilirubin. Some labs will give total bilirubin and indirect bilirubin so that you will calculate the direct. Indirect bilirubin is just the unconjugated bilirubin. The direct is the conjugated. So when you have indirect bilirubin markedly increased in the body, that means there are lots of production of bilirubin and they are not being much conjugated. So it could be from hemolysis. So when you have direct bilirubin marked in the blood, that means that there is a backlog. So the liver was able to conjugate it, and there is a backlog. So possibly there is an obstruction post-hepatic or after the liver, possibly in the biliary tract. So total protein was normal, albumin was also normal. That means it's something acute. So usually in chronic liver disease, the synthetic functions reduce. So the protein, the albumin level reduces, and the clotting factors also reduce. So that's when you get to see gross ascites and all other manifestations. So the questions over here are: give 3 differential diagnoses and what's your most likely diagnosis. So I think everything is clear over here. We talked about much. So the differential diagnosis are acute viral hepatitis. So usually when we say acute viral hepatitis, the most common ones are the hepatotropic viruses. So the hepatotropic viruses, we have hepatitis A, B, C, D, and E. So hepatitis A and E are fecal-oral, and they usually cause acute hepatitis. And the E is noted or notably causes fulminant hepatitis. So you have the infection then within few weeks. It could be 2 weeks for people with no underlying hepatic condition, then 8 weeks for people with underlying liver condition. Then they'll start to deteriorate or show severe symptoms. That's what we call fulminant hepatitis. Now, hepatitis B and C are transferred through body fluids. So it could be blood or any other body fluid. So usually they get it from sex or blood exchange of blood in any other way. So our patient had a risk factors for multiple sexual partners. So it could be acute hepatitis B or C. Now, all the hepatitis viruses cause acute hepatitis. However, B and C are noted to cause chronic hepatitis. So from the acute stage, it could either resolve or continue or progress to chronic hepatitis. That's for the B and the C. Now, hepatitis D depends on the DNA of hepatitis B to survive. So usually people who have hepatitis B could be infected, super infected by hepatitis D. So usually when we treat the hepatitis B, then the D also resolves. Now HIV infection could also cause hepatitis. So usually those that are not hepatitis A, B, C, D, E, we call them non-hepatotropic viruses. So HIV is one. You can have cytomegalovirus, you can have Epstein-Barr virus. So all those viruses could also cause hepatitis, but they are not that common as compared to the hepatotropic viruses. Then alcoholic liver disease, our GGT, even though ALP was a bit high, GGT was quite uh, within an expected range or acceptable range, even though it was minimally high. Usually, ALP could be high in biliary tract abnormalities. It could also be high in bone abnormalities. It could also be high in pregnancy because the placenta produces a lot of ALP. Now, it could also be high in pediatric age, in infants or especially neonates. So when you are interpreting the lab, you should take into consideration all these factors. So the gender also counts, the age of the patient counts, if there is any other comorbid condition of the patient. So you can't say ALP being high in a pregnant woman means the woman has a liver disease or a biliary tract abnormality. Take note of that. So my last note over here is always interpret the lab in context. So do not just interpret the lab in isolation. Always compare and then take the patient's history into consideration. Thank you very much. You can share your comments, and when you need videos on any other topic, you can put it in the comments box. But most importantly, subscribe and like this channel for more videos. Thank you very much. So we meet next time. Bye.